Great. So I thought we should start. We are recording this. Just hope that's okay with everybody. And I thought we could start by going around the table and introducing ourselves so you would kind of like know the role. So I'll go ahead and start. I'm Linda Bartniska, and I'm the director of the Center for Analysis and Information Systems. And we are the center that applied for the grant to ENRI, which stands for Network of Regional Health Improvement Coalitions. And they got money from the Robert Wood Johnson Foundation to test whether or not this total cost of care met these measures that were created by health partners and you know, an HMO, I believe it's an HMO in Minnesota, which actually got NCQA. It's the only cost measure I think that NCQA has endorsed to go out there and see if they could actually get physician practices to use it. And they started with 5 regional coalitions, one in Oregon, one in Minnesota, one in Maine, Colorado, and Oregon. Did I already say Oregon? Maine, Oregon. So, and then after the initial phase, they decided to open it up to additional participants, and we applied and were selected, and also Utah was selected to join the group. So we're sort of newer. This is our first time at doing this, but we've gotten a lot of help and support from the states that went before us in terms of doing this and kind of how they rolled it out. So we're doing it a little differently than they did it, which was, I think they all of them sort of, their big lift was trying to find practices that they could sort of engage. Whereas we said, we have practices who are engaged in PCMH and are really pretty savvy about this concept. The idea that the total cost for the patients for whom they are the primary care clinicians matter, and they might want to be able to affect that. So we are so blessed to have you all say yes. We're really grateful for that. And but we're not doing the data analysis. MHCC isn't doing the data analysis in-house. Hilltop is doing that analysis, and when we go around the table, they'll introduce themselves and explain.
Ben Steffen from the Maryland Healthcare Commission.
Hi, I'm Pat Zapp. I'm a family physician. This is a very interesting conversation for me because I've been running an ACO. Now it's in its 4th year, so claims data is very important, and stories to share with you about what physicians look for in terms of actionable information and what changes behavior and what doesn't change behavior. So looking forward to the conversation, what other people have to say.
I'm Laura Spicer with the Hilltop Institute at UMBC. If you haven't heard of us, we're a nonpartisan health services research center. A lot of our work is with Maryland Medicaid, but we also work with other state programs like MHCC. We do a lot of work with claims data. And this particular project, we're helping MHCC with all the data analysis. And so, you know, since I work on a daily basis in the weeds of the data, it's nice to come to a meeting like this and actually meet with, you know, potential users of the data.
And my name's Chuck Bentley. I work with Laura at the Hilltop Institute, and I'm one of the people, several who aren't here, who are working on and analyzing the data, the point being to make it useful.
I'm Dwayne Overlander. I'm the CEO for Columbia Medical Practice. I'm also on the board of CRISP and have been involved with the analytics and reporting efforts out of that entity. We are in the 5th year with CareFirst PCMH program and the 3rd year with the Johns Hopkins ACO. Obviously, analytics and costs are an important part of what we're trying to examine, so very interested in this program.
We also have an internist, the president of Columbia Medical Practice here with Dwayne.
very interesting subject. As he said, we have been participating with PCMH and at ACO. It's been a great education for us and for me as the leader of the physicians that I am president of. It's been a growth curve, but it's been a very interesting ride with it. And I would like to participate in it to kind of get some knowledge and give you some of my feedback to what we've done so far.
Carol Reynolds, Medical Director for Potomac Physicians and President of the LifeBridge Physician Network, and the exact same experiences.
I'm Melanie Cavalier, staff at MHCC, and I've worked with many of you on other projects that we have here going on at the commission.
Mm-hmm. I'm Janet Ennis, also on the staff of the commission, and I work under Linda's Center on this and a number of other APCD initiatives.
My name is Kaji Estrapa. I also MSCC staff, and I work with Linda providing analytical support.
Okay, so I think probably we can go right into it.
Sure.
We're recognizing that we can get you out of here a little early, everyone, on a sunny day, wherever they are. We appreciate that.
That's rare here in Seattle, right?
Okay. This presentation is, since all of you have some experience about MACC and been exposed to some background about the total cost of care, I won't spend a lot of time on that. But what we're here to do is to start the process of designing a report that is actually useful for a practicing physician or physician group that a physician can look at and work with his or her colleagues to interpret and explore the cost of their practices and how to make them better. So I'll give you that background on total cost of care. I'll talk to you some about, but mostly try to pose some questions and try to get some input and discussion. The key things are going to be how to summarize that data to make it sensible, and then given the summary, what do you do, what levels of detail do you need to explore causes and to do interventions. If we can accomplish some things tonight, if we can find some information most useful, what do you want on the front page of your report that you might be getting from this project? And what would attract you? What would give you a sense of the kind of things that this is valuable information that you can act on? And given that, what kind of detail do you want? What types of services are it things like differences in types of services? Do you want to know about your population serving? Do you care more about the clinical conditions that you tend to treat? So that's the issues that we are hoping to lay out and get some answers from your input, so that as we design, working to design these reports for you. So let me emphasize, your participation is very valuable here, and we're grateful for your taking your time out of your busy schedules to come here. Question anything, and any ideas that you have that are presented to you are very welcome. But the things to be mindful of, though, is that we are hoping to keep this kind of reporting succinct. That's part of what would make it actionable, I think, is that there is something that is a good summary of information and is not burdensome to go through. We want to be thinking about the feasibility of the measures and also some of the things that we might be ideal in some position in some situation that we could give you that data might not be ready just right now in this first go-round. As we stated, Health Partners of Minnesota has this total cost of care measure. MACC and Hilltop are partnering to work on the MACC with the medical care database to develop the measure. There are now 6 other states besides us who are working on this project. And the total cost of care index that was developed by Health Partners consists of 2 elements. there's a relative utilization index and a price index. The relative utilization is a measure of the rates of use. The price index comes from the allowed charges that are reported by payers, by the insurers that feed their data into the medical care database. So, and multiplying those together, you have a ratio measure. So one measure might be higher than another. Multiplied together, they might add up to they might multiply through to a high ratio, as in the case of the first row, or it might have a low ratio. Their data are separable in terms of what is purported on professional claims, what's purported on institutional claims, whether they're outpatient or inpatient, and separable in terms of pharmacy claims that are submitted by your patients.
So on that, go back to that question, just so everyone's clear. This index, it's calculated over what? It's calculated over every single patient, or is it calculated over an entire practice or a segment of practice population?
It's there. The data are calculated from a population that is attributed to the practice using certain rules. Among those criteria are the patients that have been enrolled in health insurance for at least 9 months, that they have seen a provider in your group. Whoever is the most frequent provider basically is the indicator of who you are given credit for, but your population is compared to other practices that are also being measured in this same way consistently across the state, essentially.
So it's an aggregate measure, but you wouldn't have a TCI for each individual patient that was attributed.
No.
That is probably.
It's a practice level.
It's a practice level.
It is a practice level measure.
Could it be broken down by segments of your practice, say?
If there are sufficient, the number there needs to be a minimum number of patients to be, and the rule is about 600 patients for a practice. To look at you wouldn't be assigning the TCI to the patient, as we said. It is to the practice, so you wouldn't be looking at the demographics, the patient differences between demographic groups within the patient, but you would be able to see some things about that group that we could calculate separately. If you had,
at least 600.
If you had at least 600, you'd be able to tell something. We'd be able to tell you something about the male-female ratio, the age ranges, and so forth. But per se, to say that women in your practice have a TCI of 1.1 while men are 0.9 or some combination like that, that's not how the index works.
But is it NPI or tax ID driven? Practice, you say at the practice level, so.
It's at the tax ID is used to identify the practice. So, our first question to you all is, what do you want to see, assuming a one-page summary or dashboard? Our initial thoughts were that you would be wanting to be able to compare your practice to other that are similar to you. We are standardizing the data by a risk adjustment method used at Johns Hopkins, the ACG grouper, so you're controlling for case mix. And so, given that, what are the basic explanations for differences you might see? Is it, you want to, we're thinking the risk score, of course, would be useful to say whether you have a more or less risky population relative to the state average or another comparable group. You'd want to know about, assuming you'd want to know about demographics, are disease conditions useful to you? Excuse me.
Can I ask a question even before we get there?
Sure.
So you said this program or this capability was first in 5 or 6 states, and now it's being opened up, as you said.
To a couple more, 2 more.
So it's being opened up, I guess, because something good happened in the initial cohort, and if so, what was that? What did this change?
So my impression actually is that the reason the project got continued and they decided to fold more people in was because they didn't get as far along as they thought they would get in a couple of years. There, a lot of the sites saw a lot of data challenges, and so they were able to fold out what I would call more like the kindergarten or elementary school version of the findings. And people, they got some interest. People found them interesting, but it's unclear to us, to me at any rate, and maybe you can correct me, Chuck or Ken, that anyone said, oh, I found this really useful and this is how I can use it. And part of our suspicion was that because they started with what I would call an entry-level set of information, almost every practice, they told us, came back to them and wanted more information. But the grant funding was pretty limited, so at that point, a lot of the states thought that maybe they would try to get people to begin to buy it. But you're buying what has yet been proven to be useful to anyone. Awesome. So we've taken a slightly different approach, which is we would pick more sophisticated people and take our money and see how far we could push the envelope in terms of giving you information that you thought would be actionable. This is really important to us. And if you found it to be actionable, then we would be in a position to be able to go out and try to recruit people on the basis of the fact that you all found it to be actionable. How is it that one of the things we wanted to clarify was the way, and I think Ben was alluding to that, is it's not actionable in terms of managing individual patients, but it is potentially actionable in terms of finding cost savings in how your practice deals with its patients. So let's say we were to do this and you were to find that you had above average ER utilization in your population. And then maybe there's some way that some changes you need to make to keep your patients out of the ER that you could do from an organizational perspective. Maybe that you need to change your referral patterns. Maybe you're sending, one of the sites has a joke that they like to tell where, when there were very high costs for patients with a certain kind of ailment, and they all joked and said, well, we know who that doctor is, and if you were going to refer, that's not a doctor you would want to refer to if you cared about total cost. So I think the point is we're not exactly sure. If we were, then we could say to you, people have been using it for this, this, and this. But because they can't tell us that, we're sort of hoping that we'll do our best to give you actionable information. You'll help us shape what you think is actionable. And if you don't find it to be actionable, that's feedback I don't have a problem saying. We did our very best, and they said, just not that worth it. I'm not going to pretend that I know that would be true. I think they would love it, to be the reverse, because there is a place where, in this world, where physicians do need to begin to pay attention to cost, as opposed to in the past where one of my physicians said, we weren't supposed to pay attention to cost because that's not how you treat patients.
So just so we're clear in terms of the population, why don't you talk about that? So it's not Medicare, but we hope to include Medicaid and the private market. The data for both of those segments would be relatively comprehensive.
We're initially working with commercial data. Medicaid data might be added later. It's not considering.
And tell them why. Tell them why, because it hasn't been tested on Medicaid.
It has not been tested by any of the states on Medicaid yet, and we'd like to be able to participate in that test. But the initial activity has been with the commercially insured population. So it is not being Medicare. It'll be under 65. We're also limiting the lower age to 1 to take out the issues of neonates who might be especially expensive. So we're talking about the typical family practice or internal medicine or peds population.
Right. So
Well, how does it seem like it's not so very different from just a relook at the Care First program and its data? I'm sorry, I don't understand. It seems like that's pretty much what you're looking at.
Well, I'm not familiar with the Care First program, but it is. But I would say that this index being created is based upon the standardization of the measures that is going to be nationwide. So it does have an NQF certification. It is going to be the kind of data. It is trying to sum up in just those two numbers multiplied together into an index that relative ranking rather than an absolute dollar figure or what you're responsible for. So it helps. So it should help in scoring yourself in some fashion, whether you want to hold yourself to a particular standard or compare yourselves to other practices or however you want to operate. Use this if you find this information useful.
So I would ask you, since we don't really know. I mean, from my perspective, Care First is a bit of a black box as opposed to transparent, right? So
well, I don't know if this is transparent yet, but it's just that so far
maybe you
it
could tell
sounds
me. So
similar.
Someone told me, I discussed it with a physician who said it sounds similar, but that he never found the information he got from Care First to be very useful in modifying his practice. Have you found it to be useful in modifying?
Well, some of it,
Okay.
the ER utilization, if that's what we think we can change. Some of us are, our practices are in networks. Maryland is lots of integrated networks that draw lines, and so frankly, sometimes your network, the inpatient component of your network kind of define what your costs are going to be, sometimes regardless of what you do. So it'd be interesting if there's going to be a slicing there to just, I guess, be more clear, even though we all know what the answers are, how your network impacts your cost. But we kind of know that already, right?
Correct.
We know that already.
And Linda, I have to point out that Care First does allow you to drill down to the individual.
Absolutely.
Oh, they do.
Yeah, very much so. And that's probably where the most benefit is, that, pointing to somebody.
So so for patient management, you would say?
Well, for a physician management, if we have a large group of doctors, PCMH has allowed us to give you a measure with your peers within the practice. Good examples, the ER utilization, access to you as a provider to get appointments. You can drill down to a lot of information with the specialists. We talk about they have bands, the more expensive, the less expensive. Not that you're going to change a lot of because I don't think you can go to the level and say you do not order to, you don't refer to this doctor because he's red or something. But just the pattern of wisely choosing the right approach for certain patients and the data has been very helpful.
So do they do, this data is cost normalized, right, Chuck?
Sure.
So in other words, so the way the cost is adjusted would be, so let's say, you're an academic medical practice, and so Care First negotiates with you and gives you a higher rate for every E&M code. They get more than other places.
No one knows that.
So without adjustment, even if the person got the exact same care, but if they used Hopkins physicians, the raw price would be higher. So in here, they have sort of a reference, like a fee schedule, to which they assign a standard price for every CPT code so that it's normalized. That's an important difference. So I wondered, does Care First normalize that?
It wouldn't really matter. Well, yeah, I guess it would. It would matter.
It does when you compare across
I think
the state.
there's actually a technical problem with the Care First data, and that's something that we've pointed out to them, and I don't know how that will will then affect your analytics. Their method of dealing with their award program is to increase the fee schedule according to the results with respect to controlling costs. So for us, as an example, we have been fortunate to do quite well in that program. For this past year, our fee schedule has nearly doubled. So if you look at the average office visit under the normal fee schedule, which is approximately the equivalent of Medicare, that might be around $100. Our patients are paying, in some cases, as much as $180 for a visit by virtue of that program. The explanation for that from CareFirst is they're required to fully adjudicate those claims, and therefore those costs have to be passed through to the employer or to the insurance product, rather than administering it as a shared savings program where they might give you a lump sum payment. So by virtue of that, looking at your matrix, for example, the majority of the CareFirst program, CareFirst providers and groups that have done well are going to appear in that high-cost quadrant.
That wouldn't be true here, right? Because we're going to get the fee for that E&M code.
Well, that's what I'm wondering is if you're going to normalize it, meaning
Yeah.
if you're going to apply their standard schedule.
No, not their schedule. It's a schedule that's internal to the tool.
Which,
Go ahead.
okay.
So yeah, there's a schedule that's internal to the Health Partners Total Cost of Care tool, and one of the reasons they did that was so you could compare costs across the country.
Got it.
So that
good.
E&M code has the same price within the tool.
Ironically, and Mr. Burrell's own materials show that the total cost of care for the CareFirst population has risen.
So what's that? So just as an aside, what does that have on your continued success? I mean, does that mean you hit
Nobody
a ceiling?
believes it'll last forever,
Right.
but it's super cool right now.
Mm-hmm.
And valuable. So I'm sure we're going to get to the super cool valuable here.
So, yeah, why don't you, I think if you walk through a little bit more, I think that we're at a pretty high level.
Yeah.
Well, just a quick question. Are ACGs then being applied to all the data and across? Okay.
Yes.
Not just in Maryland, but
Oh, yes, and all the other states, yes.
So the advantage of this would be it's normalized, you generate a comparative value. That value could be, you could benchmark a practice against other similar practices here or across the country. The disadvantage is there's no drill down capability that once you flag this, you're not able to drill down and pull out a particular patient's index score individually, so
That's
not
correct.
as effective as a care management tool.
Right.
That's a little black box like.
That's
right?
what it makes a black box, yes.
Right. And we would have had, it would have been impossible for us to do it anyway because when we get the data, it has no patient name.
I hear you, but you were just commenting that the CareFirst program, some folks, viewed it that way. You couldn't, but, actually you can. But this is, absolutely the reverse. You cannot.
And the data would be multi-payer,
Right.
not single payer, so you have a broader cross-section of your patient panel.
Right, and I did right.
Go ahead, Chuck.
Sure. It's all, as we're driven by the data set in some ways, and that creates advantages and limitations. We have, as I said here, it's organized in terms of claims, which are professional services claims. They're separate from institutional claims. They're separate from pharmacy claims. And the cross-cutting questions, you brought up one that hadn't even occurred to me, that if you are looking at trying to get down to the patient who's driving a cost, that's not something we can get to in this measure.
What about groups of patients? Are you able to, and I guess the question is, maybe, are you talking about reports, or are you talking about, say, the ability to use something like QuickView or other filtering of the data to look at population groups, subgroups?
Well, we would be able to do it here, for example, with just taking the example of professional services. You could separate out, you're not necessarily looking at the patients, but you're looking at the services, the claims, whether surgical or medical are more or less expensive or more or less intensive. You can look at the types of imaging services. You could look at ED use. You could look about kinds of patients as we've described them, as we described earlier, whether to drop them out, to pull out children from adults or by age, within age groups. But the among the measures here too are also things that we could be using are diagnoses.
Chuck, if you could show them, this is a good time to actually show them an example of what it looks like if you do it by certain patient categories, so that we're not.
That's not in this version of the set, but if you if you had a measure or a way of classifying people by chronic diseases, and some of the ACG allows that to a degree. There are some choices that you could make about those classifications. You could talk about persons who are primarily ascribed to be asthmatic or arthritic or having diabetes or other types of chronic conditions. So you could look in terms of the types of conditions that are driving your costs, not necessarily the patients themselves.
I think we need to see table shells. I think it's too hypothetical without some sample table shells, right?
Sure.
So
It doesn't sound too hypothetical. It just doesn't sound new.
okay. So maybe you can tell us that,
right?
If they look the way you think they would look. I mean, do you get reports that way so that you can see how you do with your asthmatics, diabetics?
Specific conditions like CHF, COPD.
We know who they are.
Right.
Okay, so what kinds of condition categories are they using, and are you happy with those? Are they HCCs? Are they, how do they create the
You mean how they attribute to patients, or
well, how do they
use the
define,
cases?
how are the categories defined? Because, there are different groupers.
Right.
So do you know, are they using a standard grouping system or one that they make?
It's proprietary.
Okay.
I haven't followed it too closely recently, so you guys correct me, but it's an illness burden score, first of all, to get your really high risk. So,
okay.
the super high, they just put into special care management. That rising risk, they really want to point to the patient-centered medical home and say, here, manage these patients better. But within even those hierarchies, they'll group with chronic conditions, diabetes, asthma, COPD.
So they use, are there 10? Are there 200? That's what I'm asking.
Volume-wise?
Top
The
50.
number of categories?
Top 50, I think.
Okay.
It is a top 50, but, it's limited in that it's not every Care First patient. It may be if there's some self-employed groups that don't want to participate or something like that, maybe they're not included. So it's not necessarily all of your patients, but for what it gives you pretty well if you want to utilize it.
Linda, I think they just use the chronic categories, asthma, COPD.
The usual.
So I think there's probably about 7 to 8. That's kind of about right. Asthma, diabetes,
The
COPD,
big one
CHF.
that everybody.
Yeah, I think if that's what you're asking. Right. I guess I was, so that the Medicare has the hierarchical condition category.
Yeah, they don't. It's
But
like
they don't use
ACC.
It is like
Right.
the ACC.
Somewhat. They also do a sort of episode grouper. They look at a hospitalization and look for the predominant condition and then profile the cost and patterns associated with that. So there are a number of different ways of cutting the data.
I'm not sure there's much cutting. Is there much information regarding imaging, you think? I mean, there's a couple of small measures about when did you image the back or something like that, but I don't know what you mean when you will slice it for some actionable way on use of imaging services. I don't know what you mean.
Maybe imaging actually is a better example of what the Medicare Shared Savings Program can do. Our ACO, we order I shouldn't say this. I should say this carefully. The patients attributed to our ACO get a lot of MRIs. So we presented that data to our ACO primary care physician. Well, sure, they sure do get a lot of MRIs. I didn't order them.
Right.
So you have to look at the data, say who
Right.
ordered the MRIs, and then they say,
Exactly.
well, what kind of MRI was it? And so there are these multiple onion peeling, and I wonder if one thing that really frustrated me with Chet's program is 2 or 3 years ago we said to them, look, you're coloring everybody, all the specialists, not the primary care docs, red, yellow, green. Are you telling the specialists? Because we really want all of our specialists to be at least yellow. Yellow is actually okay, by the way, if not green. And have the green guys talk to the yellow guys and the red guys and say, here's what you do. But we couldn't get that data to them. It was, other than telling people, like in the bathroom, you've got spinach in your teeth, you're red. But they didn't know why they were red.
Or how it impacted them.
Yeah.
It impacted them.
Yeah.
Well, in some ways, I mean, I am, in my practice, I'm trying to get a collaborative group with the specialists because of this very subject. I try to get the orthopedic doctors, and they immediately, when you talk to, they know about red, gray. Oh, they want to know where they are, and you know they kind of know where they are in the rankings. And what we're trying to do is we're trying to get like the 3 largest practices of orthopedics with us, and trying to create access to avoid having those MRIs and everybody knee pain MRI.
Right.
No, getting the access to that orthopod and say, okay, I can get you an appointment quickly with that doctor. I have an agreement, sort of like a gentleman's agreement with them that I will have a same day, next day, or a reasonable timing to get that patient with the knee pain, because they're the ones that are feeling the pain. And if you tell them, okay, we can see you in 10 days, like, doc, I'm in pain right now. What do I do? And so they end up in the emergency room. They end up in a primary care patient first, or one of those type of and then they get that MRI. And then when they give us the data, they say, oh yeah, that's my patient. The MRIs are usually not the ones. Trying to impact that by talking to them. They did that with we done it with orthopedics, we done it with GI, and we done it with urology. And that's trying to get conversations, a dialogue with them to try to create more two-way communication with them. And the patient is the one that gains it.
All right, so you said orthopedics, GI, and did you say neurology?
Urology. Those are the main, the 3 that we've seen. And then we got the data of the 10 to 14 most popular diagnoses of people going to the emergency room or to the patient first or the convenience care or urgent care. And then we're trying to see if we can use that data to see who do we need to talk to, who do we need to kind of create synergies with.
Can we jump on that concept for a minute?
Sure.
Because
you know what? You guys are so sophisticated. You can run the meeting. Go.
No. What I'm thinking of. Okay, so don't try to recreate Chet's wheel, right? You can't. Well,
what would be the
Medicare
point?
ACO
What's the point?
Yeah. But maybe can you figure out how the niche you could fill is making clinical integration to a certain degree happen between the primary care and docs and the specialists. So you get those conversations. You're starting to share performance data. Hey, you are a red, or we'll call them a Y, or whatever you're going to call them in your program. And here's why. And here's how you stack up with your other colleagues. We want you to know that because MIPS is coming. You're going to get scored. People are going to stop referring to you. We want to see you succeed.
The endocrinologist was another example. We have you try to get in my part of town. Try to get endocrinology consult is very difficult. Yet, I have patients of our practice who are being seen 3 or 4 times a year to check a TSH.
Right.
And I said, you don't have time to help me with this really tough case, a real diabetic or somebody who might need an insulin pump. But then you have these people that are being seen on a regular basis to check a lab, or you draw the lab in your lab. So those are the things, I mean, let the primary care doctor take care of that TSH, which is a regular visit, and then you open up a space for us to give you those data. And if they are in the emergency room 3 to 4 times because they are not getting the appropriate care because they're difficult, sometimes we do need the special.
So when you said, I'd like to go back to your comment about this integration, you were saying that what the tool that Care First has can't do is they won't give the information to the specialist.
They won't. We actually begged and pleaded, and this is interesting. I'm going to share this, and I know I'm being recorded. 2 years ago, 3 years ago, we said to Chet, we really want to see our entire medical community do well. Can we meet with the cardiologist and the orthopedist, because you say they spend so much money, and can you give them a presentation, and then can you tell them what goes into this cost calculation, and then we'll quietly, at the end of the meeting, we'll each in an envelope hand them their own report card so they know where they are so that they can improve. Wow, it's a great idea. We met with great enthusiasm. We'll get back to you. And we waited a couple months and called back, and they said, well, our data are old, and we just got new data for the last fiscal year, so we're scrubbing that. And they even got to the point where they showed me and my boss a report. Here's what we think we'll show the specialist. What do you think? And they're really pleased with it. And I could tell it was a beautiful thing. And it was for a cardiologist. And there were not completely unrelated cardiology costs that these guys were being dinged for. So that I really lost an appetite for pursuing that because obviously, like everybody else, I'm there too. They have data problems. The data aren't clean. They probably need to be scrubbed by a clinician who can say to them, and that's what they were doing by showing us the draft report. No, take that out. So if you could use these data points to somehow give specialists clean data on how they're performing, you could really get the state ready for phase 2 of the all-payer model, and you can get these docs ready for macro.
And can you provide the information by network, though? I still feel like the networks that many of the practices are in, constantly more and more practices are being added to networks every day, define, they shouldn't define, they kind of define, it's not a stark issue, define, but define your specialty group, define your urgent care group, define your inpatient group. That's just, Maryland's being cut apart like that right now. So are we suggesting that we're gonna compare networks to networks? Would that be interesting?
So
Would that be valuable? Or do we already know that?
So this particular tool, I think, is thought of as we are doing something like that on a different initiative and thinking about it. But this particular total cost of care metric was envisioned as something that would be used by individual practices. So, I think we're sort of stuck here a little bit in terms of beginning to think of, we want breadth and we want depth. That's what I'm sort of hearing you, the ability to, what we would have is all-payer data, but we've got to figure out what the depth means. Does it mean, it's hard for us to say you could provide patient-specific data because there's no, at this point, patient ID on the claims that we get. But then you say maybe depth, we mean across the primary specialty continuum so that you can see, okay, for this practice, how does that index get sort of carved up by the specialists that are being supporting that?
Yeah, if I can pick up on that and maybe combine with this idea of specialists, and particularly in the context of ED utilization. We've looked at a study that was funded by the Robert Wood Johnson Foundation about 10 years ago, and it focused on New York City, and they developed an algorithm to analyze claims data associated with the ED utilization, and maybe you're familiar with it. I've urged actually that CRISP build that into the some of the analytics that they're doing. This is very consistent with what we see both with the ACO and with CareFirst. We have about 15,000 people then that are subject to are being able to go down to the level of, we've asked for both urgent care as well as ED utilization. What the ED utilization confirms is that about 20 to 25% of those patients, based on the discharge diagnosis, needed to be seen in that setting. There are a large number of patients, though, that could have been seen in either specialty or primary care or urgent care. And the result of that, I think, for us, linking into what Dr. Salwe was describing, and I think it's applicable, is to start to be able to judge the order of magnitude of patients who had conditions that could have been seen in specialty settings on that same day, next day basis. And that kind of level of analytics is not something payers are willing to do because they're fearful that they will be seen as intruding upon the medical decisions that are being made by providers. So as a result of that, as the discussion about MIPS, is we're sitting with data with absent a neutral party that could apply that type of analytics to provide insight. And the material impact of that is significant, as we all know. It's $1,000 at least on average for us for every ED visit. And a specialty visit or a primary care visit are going to be an order of magnitude of 50 to 75% less. Most of having been a hospital administrator, most of the ED visits, the patient ends up either needing to be seen by the PCP or the specialist. In many cases, the specialist is going to be instrumental to getting that patient into the path of care that's needed. So by having that type of information, there could be conversations with the specialists about improving access to then facilitate this alternative pathways for care.
Wow, that's really good, but you're making me think I need to call Henry and say we're dropping out of the program because they want us to do something the tool doesn't do. I mean, that you're really, I'm not.
We're just being
Well,
honest.
if you can get the claims data, the SAS algorithm is written,
We actually use it routinely on Medicaid data.
Oh, you do?
At
Okay.
Hilltop, so we're very familiar with the NYU algorithm.
Once we've created you can do these, some of that kind of drill down of characterizing ED visits as being avoidable or not, as NYU calls them. But it's sort of a separate analysis.
It's separate from the tool.
Yeah.
It sounds like everything you want is not in the tool.
Yeah.
But I think it's what's actionable. And it is,
No.
and it is the conversation.
Yeah.
I say to a cardiologist,
That's perfect.
I want you to do the following, and they say, how much business?
It's just,
What are we going to get?
but we still can only have so many actionable tools,
Right.
or we don't have enough people to use them. Thank you very much. But even if this was completely actionable and it includes everything, but I have to still do this special thing over here for the CareFirst program, unless your tool is so good and has the depth that it would be needed, so that I really wouldn't have to work the CareFirst tool at all because it's still all here. It has to save me time. I can't work it all. I can't work everybody's tool. It's just not possible.
And the problem with the iCentric tool, which is CareFirst, is it's a 5-year-old technology, so it's very difficult for the end users or even somebody who understands how to use it to really produce meaningful information. If you want to invest the time, it works to a certain extent, but that's the downside of their analytic tool. And we've used ACGs now for 3 years with the ACO, and it's helped provide some insight, but it too is kind of this flat report, and you can't really go and say, I want to look at the population and derive from that information.
Old data, as soon as you get it.
So I am hearing some pushback, realizing among things that, yes, it will be a flat report as you cost it. It's 2014 data, which is lagged, and but we are we're trying to derive from you all, thinking in terms of the limitations of what we are working with. If we produce something that is that kind of report, what would you like to see? If we can pull out some things like doing a separate analysis on ED as whether or not they're avoidable utilization or admissions or avoidable ED use of that sort. If they're, we've looked at examples from other states and trying to pull together this presentation, and there are production of comparative charts and so forth. And some of those went into the email, the letter that you all went. Whether to derive you, whether to put you in one of the four corners of the box, or place you in a histogram and rank you. This is not a tool that's good for attributing things to particular causes, but it's about looking for patterns. And that's what we'd like this process to result in, the sort of patterns that are meaningful to you. Again, considering the limitations.
So I guess maybe thinking about your Care First information. Since they already know, what do you like that you would, so let's just say this is a dummy test between Care First and this, and that we'll try to perhaps look at ways we could enhance the information that we give you by doing potentially avoidable, admissions or ER visits, those kinds of things. So in your Care First reports that you get, which by the way, I've never seen one, maybe it would be great if, have you seen one?
Not for a while, but yeah.
It would be great if we could see one. So what do you like that's in it? So we can at least replicate that.
You don't want to just meet with Care First and review it in detail and learn from it?
Yeah.
You want to do that?
But you could tell us what you like, right? Because we would like to replicate what you like.
I really like my increase in fee schedule. So I'm really excited that you're going to replicate that.
Sorry.
That's why I like it,
So they're
not a game changer, really. You can get a lot of the same information from your own EMR if you know how to work it, so I can't say. CRISP now is like, you can find your patients that are your frequent users of the ER. You can find your frequent folks who get hospitalized. You can get that from the hospitals directly. So many more people have so much information that they share readily. Having it in one place, that's all good. But if you can't fix that problem, it's just going to be more information.
Well, I think that's what we were thinking was. So it's not if our report could do what Care First could do, but also do avoidable ERs. Would that make it better or not? Well, we can't do the drill down.
Probably, I think what people are saying is, in terms of the TCOC metric is NQF recognized. It would apply across payers. It would, but it can't be, unless I'm being measured on TCOC Health Partners, if I'm being measured on that, then everyone pays attention to it.
Exactly.
If I'm not being measured on it, it's just more noise.
It's just more noise. That's why I'm trying to tell me how it's not more noise.
What you're telling me is go bring Health Partners in here, which is, of course, a Midwestern health plan. If you really want us to get interested in this metric, get the payers interested in the metric.
Yeah.
This is a better, we all ought to use Health Partners TCOC, and if that would be helpful for me as a
I think there's an intermediate step, and I also think that the MHCC and other organizations are taking leadership in trying to answer that question. We don't get any information from Aetna, United Healthcare, so 60% or 50% of our population. With Care First, yes, we do get data, but we don't get anything that even approximates that. So it would be very helpful to have this broader picture of the private pay and commercial sector of the marketplace. And I think that also, if I look at least at this sort of illustration. It would be helpful to see, I don't want to say specially, but disease, at the kind of the broad scale of disease of cardiovascular, where does it fall? And understand then, because we do see variations. A lot of it's related to where patients are going for inpatient hospitalizations. And so you can see that tiering. That's part of the concern that Care First has. I agree. I think seeing the Care First eye-centric reporting would be helpful. What we find is useful, we monitor ER visits compared with the norm of the other PCMH groups. We look at hospitalization rates, so you get a graphic display by month, and that is an important indicator of where you're going to be the following year in terms of the Outcome Incentive Award. And then I think there are 6 or 7 major areas that they sort of monitor that are kind of key metrics. There are probably 15 different report categories in total, and there may be as many as 100 reports that you could generate out of that. I think part of the challenge, as I said, though, to have the information be useful is it's so labor intensive to be able to run these reports, and you can't put them together to create a picture. So it's like you've got this piece of the puzzle and that piece of the puzzle and that piece, but you can't get a coherent look with their tool. That's the major limitation that at least that we find.
So if we thought about this end to end, it might be that this tool would be, it might be possible to break the payers down. You have good data, pretty good data from Care First patients, but you don't have much at all from, I mean, we have had similar problems with United and Aetna, who are always just about ready to have their PCMH program, dusted off,
Right.
and it's always, we've asked them for, it's nearly ready, we're going to do this, or Cigna has one practice, I think, in the state, but the absence of that, I mean, in some ways they are free riding behind Care First, but in some ways what I'm hearing is it would be really useful, perhaps if it's delivered in a similar way, perhaps through CRISP, although we're still very much in a Henry funded through Robert Wood Johnson, just giving us a little money to think about
Very
this.
little, yeah.
Think about this, but sort of the delivery matters, how it will be delivered, a consistent delivery mechanism. Can't drill down to the patient level at this stage, but if you could drill down by different payer categories.
That's dependent on the patient panel side. So I would say.
Yeah, well, just let's
yeah.
blue sky for a little bit. That I think that Kim's not here, so I think we would have pretty large, sufficient patient panels to do some degree of.
Well, I was just going to ask, could it be Care First and everybody else together, or would you need to see Care First versus Aetna versus United versus Evergreen, which is
Probably all of that, but also if it's blue sky by provider. Since we have all the patients in the mix, right? You can be at a practice with 10 other providers, and it's nice to know the differences between the individuals. People practice differently. So that would be valuable to us. We rarely know that, as simply as we, but then, you got the patient volume, but if you are going to have all payers, including Medicaid, so guess what? If you put Medicare in there, blue sky, then maybe you can get to the point you can tell us something particular about down to the provider level. Otherwise, this 600, so is that going to reduce your ability to communicate with all practices? So there'll be lots of practices in the states that you're not going to be communicating with at all, right?
That's right. Especially
So what's the point of that?
with the Medicaid population.
Exactly. So what's the point? I mean, there's a point, but you know what I mean. You're just missing so many of them, and so otherwise, your dots in your graph, it'd just be all gray. Everybody would be everywhere, right?
But
all
when you actually look, there are a lot of single, especially in primary care, there's a lot of single practitioners, but in terms of the volume of primary care that's delivered, you're actually looking at probably 50 practices, 50 tax IDs are going to account for 75% of all the primary care today, because you know yourself.
We know what's happening.
You know what's happening. That not, the 25% you may just not be able to support.
Smiling because where I practice now, I'm so thrilled if somebody has insurance. When they walk in the door, it's a treat.
It is. Good thing.
So do you want to carry, I think we're getting more of a, I don't want to like keep people here for hours on end, but I think
we'll
we're
have
getting,
to.
one of the things that we purposely did was we didn't want to show you table shelves. We wanted to have a, so where it's not like we're, and actually Chuck, the first presentation he did, we said, no, not, so he was actually maybe thinking of maybe pressing it. But we said, no, we don't want to show you table shelves yet. We want to get their ideas. Maybe it was a blank sheet of paper was, maybe not necessarily the best place to start, but something I think, some ideas like coming away with are another summary report, unless it adds something, or it's very easy to access through existing appliances. Wouldn't be all that interesting to me, even if it was a very good summary report.
Maybe.
But if it was broken out by payer, especially by payers, for which we don't have a whole lot of data, now there's lots of, that might be more interesting because it would tell me something about the market that I know a little about. And then sort of drilling down further, if I can understand a little bit about where that patient population is getting care from the standpoint of,
Or she said, even if I had to group all your privately insured together, but I could break it down by individual providers somehow, some way, then at least, because it's unlikely.
And you might bring in more
It's
providers
unlikely
that way.
in my head that a physician practices differently if he knows the patient is Aetna versus Care First.
Not purposefully, but the network is different if it's Care First versus MPO, right? So, it's just that there are subtle differences, that, rules you have to follow.
One of the things, I guess, when I heard about this project that I was thinking would be helpful is that as a practice, it would be possible for us to have some general parameters to understand the cost of care broken down by what I would call sort of the actuarial categories. We don't really know that right now. We have some sense, but, is CMP $100 million in terms of total cost of care? If we were sort of an HMO, part of, I think, the analytics that would be done would start down a path of saying, for this population you're responsible for caring for, this is what the costs look like. One of the things with ACOs, at least that we tried to do with Hopkins ACO, was create that kind of framework and then apply the Milliman guidelines to start to look and say, how do these costs of care compare? One of the things we found was that as an academic medical center-oriented ACO, there were a lot of individuals who were in that trajectory of their care where they were unattributed to a PCP, but they were attributed to a specialist. So that was a significant driver of the cost. So we tried to take some of those patients out of the equation and normalize it and say, if we were looking at the 30,000, not the 35, what would that look like from a standpoint of patterns of care? And I think it would be useful for at least more than an academic exercise. I think it would be useful to be able to convey those kind of parameters to a practice to give them better understanding, broken down in these categories, and then compared with norms, I think, is kind of the next stage. So
when you said actuarial categories, I just wanted to check and make sure I understood what you meant by.
Well, what I'm referring to is inpatient, outpatient.
Okay,
those,
lab, the
yeah,
chemical
those
that you see on an
different-
insurance company.
those different components of
So the
cost.
service component.
Yeah.
Okay.
But taking the specialty attributed patients out. What do you have then? You have an exercise, but do you have reality?
Well, I think you'd still have the specialty cost in. It'd be helpful to know what the magnitude of that is. is it, now, in a sense, we may already know that from Care First, because they say that
I mean, the patients who are treated
27%
to an oncologist because they have cancer.
Right.
But the exercise was done when we did the ACO with the Medicare patients. I mean, that's it. We went down to the patients that were treated to us and they didn't have PCPs and we reached to them. We need a PCP, and we did make a difference. Some people came in, became back, had a PCP, and hopefully we made a difference on the oncologist is now, or the orthopod, or the gastroenterologist is not the PCP. We're the PCP. So my line to the patient is, I'm your quarterback. Let me do the quarterbacking for you. And they like that sometimes.
So these are patients that didn't have PCP.
This is under the ACO
Yeah,
model,
one of
which
the
is
interesting things.
retrospective attributions.
Yeah.
But the same thing happened when they gave us the data from PCMH from Care First. When we had a list of patients, I remember how many meetings I had this gentleman that wasn't there. They spent a humongous amount, and I never saw him. They finally moved to Ohio. So
How was it that he got attributed to you?
we talked to them. They tried to investigate.
We couldn't get an answer to that question.
Lots of prescription refills, maybe, or something.
It was in the hospital, in the emergency room, like countless times.
Huh.
We tried to reach and said, you need to come in. We have a program, a transitional care program. The minute that they, to Chris, we get our patients, they get called, they get scheduled, so that they don't have to come back. We tried that with him.
I think one of the things.
But how did he become yours on your list?
They could
if
not,
he never saw
so
you.
how many times I asked them about it, and they could not.
I think one of the things we're finding from
Okay.
transition of care calls is that patients, at least in terms of ED utilization, that are high utilizers, very often have a very loose relationship with the PCP. And they tend, in fact, the interesting thing about where the opportunities may lie, if you look at Care First with the illness bands, it may be in the lower illness bands where there's an opportunity to change behavior, because these patients are choosing to go to the ED as a source of care or even urgent care rather than going to their PCP. Now, there may be an access issue, but they're at kind of an emergent state of a disease or a medical problem. They experience extreme symptoms. They choose to go to the ED. They think when the symptoms go away that there's no longer a medical problem that needs to be treated. And so I don't know exactly how that would relate to your analytics in terms of giving us some insight, but I think that's what we're finding with the commercial population, more so than the Medicare. Medicare patients appear to have a closer relationship, and I know we're not including Medicare in this analysis.
But don't you think that's just because they're older and it was a different time in medicine?
Yeah.
Don't you think that we're just in a different time in medicine right now, and, we maybe should think even further ahead than keep trying to make it the same?
People come to see us in our office on our schedule.
Exactly. I mean,
Sorry,
if we don't change,
15 minutes late, we'll have to ask you to
if
go
we don't
away.
change any of that, I don't know if the rest of it really matters so much. I don't even know. There are a lot of people, everybody probably doesn't get a lot out of coming to see a PCP regularly. Sometimes you really should see the specialist more. It probably makes more sense. Convenience is important to me. Convenience is important to you. So our patients get to have convenience important to them too. It's such a narrow conversation lately.
Another insight.
Too narrow.
I'm trying to get you out of here by 7 o'clock.
Mhm.
That we want to go back to the drawing board a little bit here, but to the point of a primary, the way these attribution algorithms work, to your point, is really they look at who is viewed as I don't want to say PCP, but the principal source of care.
Right.
And so they throw out the specialist generally. So you could end up with, in a situation where this, the guy, let's call him the Buckeye, he showed up at your practice 18 months ago, once or twice. But because you're the only primary care provider who's ever seen him, they're not counting the whomever that's also treating him. So you have basically an orphan patient. And I've wondered about this from talking to Donna and others about, you know, the idea of, are there really patients that are loosely engaged with primary care that are really getting most of their care from the cardiologist or the
Yeah, that's another absolutely.
I mean, and somehow the ability for people to see that you're responsible, you're accountable for that through the ACO or through the Care First model, but you really have no ability to control it because
It's a fallacy that your primary care can control these costs.
Exactly.
right, I
Absolutely
agree.
ridiculous. And
It's
our
panic.
specialist community this is all opaque to them. You know,
Right.
They haven't been in PTMA since 2009 or whatever. And Carol and I were early. Carol was earlier, and they don't know what the hell we're talking about. Why are we kicking the specialists out? We should be actually enlightening them.
I'd like to make it even broader. I think the individual networks could really use some assistance, quite honestly, because I think that, you know, so many primaries, so many specialties these days are just really depend upon their larger networks to assist them, help them, make them understand. You know, everybody's working even more siloed than usual because of the waiver. It's making people do things odd, do things differently, do things separately, say they're working together, but we're not. And, you know, I almost see a lack of cohesion lately than more so. And you know, I'd really think that they could really use a little bit more help with all the things that we're doing, because the age of a PCP really controlling his or her own destiny is almost history. Even if they could, it's history. It's just not like that anymore. I think for a large group of the providers that you would be communicating with.
So this is like selling hats to women who don't wear hats.
Right. I mean, to me, it's a little like that. But there are some women who wear hats, but there are only about 5 of them. And they need some assistance to understand the bigger picture, you know, the really bigger picture, I think.
Wow.
Last point.
Well, I think you've heard us be pretty frank and candid.
Yeah. I might need a
So I
script
think
for
we want to go back and put this, I mean, put our thinking caps on about this.
Yeah.
I mean, I think one of the things to keep in mind, like in terms of delivery mode, you know, things like delivering it through CRISP or whatever, we're far, far from that standpoint of being testing that. We still want to have some metrics, but, you know, I think we heard, you know, a common, consistent medium through which this data passes to me. If it's not coming through the EHR, at least it's coming through something we already know, that we don't have to develop a pathway, another separate connection, another separate logon, another separate, you know, certification to qualify for this. I think that's just given.
For us, where we thought this would be sort of like one-time reports, it would be the same report with more detail. Like we would run the data. It's not like you're going to get this every month. We weren't at this juncture all that concerned about a delivery vehicle, but we were concerned about trying to give you information that's of value. And now we have to
put some thought into this a little bit, I think, in terms of, you know, this is a pilot from the standpoint of Henry, and you know, we're not, we'll have to, you know, for one thing, develop the implementation in Maryland, and then figure out if it was successful, how it's sold, and how it, you know, is it yet again hanging off that Christmas tree called the all-payer model, or, you know, is it, you know, some other means that can some private firm take it on? I think that's where this is where it's going right now. But I think there's a lot to learn yet, particularly on from some of the states that have gone further. One thing that they don't have is as much of a push from the standpoint of their HIE. I mean, ENS, counter notification, is now widespread. Almost all HIEs do that, but some of the ideas of pushing more analytic data through the pipeline is Maryland's quite a ways ahead on that.
And I guess, and I think I would say that they don't have a Care First. They don't have a Care First model
they don't have a
out
Care
there.
First, and also I'd emphasize, though, with CRISP, while we're implementing capabilities that are associated with transaction data, there still isn't the baseline. If Maryland is able to get Medicare data, certainly that in the future could provide a picture of that population, but there's no picture for the commercial population at this time. And I think, I hear the feedback and I don't disagree with it, but I still am encouraged with what you're proposing to do in creating a picture of total cost of care that allows us to look at the population.
That's, not
That could be very helpful.
That applies to everyone.
And in some ways, this has been theoretical. We need to see the data. It's like seeing the EKG.
Right.
The patient may describe the symptoms, but when you see the EKG, you start to see more about patterns. So I think there's an iterative process to this in which if you can give us some information without exhausting your budget, we can maybe give you some more
and
feedback.
we're not a state that's testing the Medicare. We're a state that was selected to test Medicaid because Hilltop has experience. But there are states who are testing the tool in Medicare to see if it makes sense. So that's the other pilots are. It's I would say both Medicare and Medicaid are in test mode, and so we would certainly one thing we could do, even if you thought the tool was redundant to Care First, we'll bring ourselves up to speed on that. Is to give you the Medicaid data as a test, right? I mean, so that you could see, whether or not it made sense.
For us, I would say, we are only in priority partners, and we get lots of data from them based on ACG. So I don't see it as, for us, I don't think it gives us any
Anybody else hot to get it in Medicaid?
Well, the thing about MCO,
know what it would do for me.
Most people are after going through the PCMH program, what we found was that most practices that applied went to at most 3, some only 1 MCO, that the idea that you have this broad engagement across the entire MCO population is a myth, that most primary care practices select a couple that they think their practices, either it's network arrangement, affiliation, or tradition, or whatever, but okay. Last thoughts, Linda?
I need a drink.
This has been very helpful. I think that I think your point is think about some prototypes that maybe we don't need to meet, but maybe do some running by you in terms of what this might look like with some of the breakouts by populations, or ideas that I'm not exactly sure how we would do it by specialists, but we'll put our thoughts together on this. I think Robert Wood Johnson, who's funding this, doesn't want to just have the participants go through this, burn the money, and be done. I think they want to. I think we can give them feedback that the practices that we're here today really thought, and we're a little different because I think we're a little bit, at least the concept, some of the concepts here have moved a little further into play than many states. So
we'll have to be more creative.
Thank you very much. We will be in touch. I know some of you participate in our primary care council, and we're looking forward to talking further. We did have a meeting with the payers, largely unproductive today, but we're going to keep plugging away on that. PCP plus. Sounds like something your kids come back with when they were 10.
We appreciate the invite.
Yeah. Thank you very much. We'll grab a sandwich as you're leaving, and
so we will think, and then we will get back to you, because I do think we want to do something, and we will do our best to not be redundant.
Okay. I think a webinar would be good.
Oh, yeah.
That's something. Yeah, I mean, I think we started out here maybe we didn't want to show you something, but I think what you're coming to say, we'd like to see something.
Yeah, maybe that would help.
Thank you, everyone.
All right.
Thank you.
Thanks.